All right, so today we're going to talk about SGLT2 inhibitors. And so the main article that I sent out was really talking about the drugs themselves, a little bit about their discovery, how they interact. Didn't really go into much in terms of the outcomes that have been seen with these drugs, but those were the complementary articles that I had sent out. There's actually a lot of articles that have been published, a lot of research that has gone into these drugs, but I tried to choose the trials that were performed in people that did not have diabetic nephropathy. And some of the papers had both diabetic and non-diabetics, and they kind of separated it. So I gave a small subset, I think there are just four, maybe five now, papers that are original research of SGLT2 inhibitors in non-diabetic kidney disease in people, because I thought that was a better model for our patients. But let's go ahead and get started talking about this drug class, which is, I think, important for us because not only is it a potential therapeutic target that we have not tried for our patients with kidney disease, but there are veterinary SGLT2 inhibitors that are in the works. You might have seen some publications that have been either presented in conferences or I think there's just a couple papers that have been published, but specifically looking at the SGLT2 inhibitors for use in the management of diabetes, just like these drugs are also used in people. So these drugs are going to come out with likely an indication of management of diabetes mellitus, which is great that we might now have veterinary versions of these drugs that we can then begin to study and look at their other roles in non-diabetic diseases. So I think it's very timely that we know a lot about these drugs, and I think we need to study them because what has been shown in people, I think if we can see some similar results in our patients, it would be remarkable. Okay, so let's start this off the way that we always started off. Before we kind of go through the sections and get into everything, I'll just throw it out. Any things that people had questions about, they struggled, didn't understand, things that they thought were remarkably cool that you want to start bringing up before we kind of dive in? Let me open the floor up to everybody to speak up if there's something that you're confused on, excited about. Happy to start talking about that rather than kind of just going through piecemeal through it. Okay, I will take the silence as unbridled enthusiasm. So let's move forward. So these SGLT2 inhibitors, sodium glucose transporter 2, these are the drugs that we are talking about. And these drugs are derived from a plant. It's actually apple bark where it comes from, and this molecule that was isolated from the bark of an apple tree, which is the Flozin molecule, was in animal models shown to minimize hyperglycemia in rats with diabetic model of diabetes added. And so this molecule was initially thought of being a cool and potentially revolutionary treatment for diabetes, but that Flozin molecule turned out not to be effective because it doesn't have adequate bioavailability. The intestinal enzymes degrade it, and so that drug never reached enough concentration within the patient to have any systemic effect. So the idea was kind of pushed to the wayside. So and I think the initial studies, I think they cited here, like, yeah, back in the 30s that these studies were first done. And it wasn't until really the late 80s that the pharmaceutical industry started to pick it up again. So 50 years went by where these molecules were just kind of ignored, and now there have been a number of drugs that have been developed and approved and are currently in use for people. And they've been approved now for almost a decade. I think 2013 was the year of the first approval of an SGLT2 inhibitor. So even though we talk about it as if it might be a newer drug, these have been around for a long time. There's thousands and thousands and thousands of people who have been treated with these therapies. So there are three, and I think there might still just be the three. There's DAPA-Gliflozin, canagliflozin, and empagliflozin are the three drugs that are commercially available for people. The veterinary ones, I think, are going to be different. I think it is bexigliflozin. I might be wrong about the exact veterinary drug that I think is in the pipeline for diabetes, but it's not one of those. Now, I've reached out to some of the manufacturers of those drugs, like Farxiga, to see if they might be interested in doing some trials in veterinary medicine, and I'm still waiting to get an email back from the company. It's only now been about 18 or 19 months or so, so I'm sure they'll get to it at some point. Because I think these have potentially a lot of therapeutic benefits for our patients, but we shall see. Okay, so the article starts by just going into the sodium glucose co-transporters, and there's SGLT1 and there's SGLT2. SGLT1 is found in the intestines, where SGLT2 is not. It's found in the kidney, but SGLT1 is also found in the kidney as well too. And here is where we have classic examples of how nephrology is made ridiculously hard when it doesn't have to be. So SGLT2 transports one molecule of glucose and one molecule of sodium. SGLT2, one molecule. SGLT1 transfers two molecules of sodium per glucose. So why couldn't we make it easy and SGLT1 does one? Of course not. We're not going to have that be the case. Additionally, SGLT1 and SGLT2 are both found in the proximal tubule. And of course, SGLT2 is found in the earlier segments and SGLT1 is found in the later segments. So it's almost back to like the renal tubular acidosis scenario, that type 1 is more distal than type 2. We're kind of in the same thing. So trying to think of mnemonics to try to help memorize this and make sense, the best way to think about it is nephrology is hard, and it has been made hard to think of how to keep all of this straight. At least it is for me. So they gave the chemical molecule of the Flozin molecule, and the big feature is that we have these aromatic rings that are present, but then we also have essentially enough mimicry to glucose that these molecules can fit in the co-transporters. And they talked about the particular molecular moieties that were essential to the class, and I tried looking it up and went a bit down a deep dive into biochemistry, and I came up without anything that was helpful. So I don't have much to share regarding the actual chemical nature of that. They talk about the structure a little bit more later in the article, so we will get to that. But you can see that all of these drugs, similar to the parent drug, have aromatic rings. They have this glucose sugar molecule, which is really what's going to allow that molecule to fit into those sodium co-transporters. They cite a lot of different kinetic assays looking at the ability of each of these drugs to inhibit SGLT2 and SGLT1, and the SGLT2 inhibitors are very, very specific for SGLT2, and that's shown in this table 1, that if we look at these various drugs, the nanomolar concentration that's required to either inhibit the rate of the enzyme by 50% or essentially do the same thing I looked up the difference between the inhibitory coefficient for the Michaelis-Menten equations, that's your Ki, compare that to your inhibitory concentration of 50%, and I don't understand it enough to explain it to everybody, other than one is um, like a thermoenergetic rate and one is just enzyme kinetic rate. Regardless, to me, I think they're saying about the same. What's the concentration of the substrate in this situation is each one of those drugs that's required to decrease or inhibit the speed of the enzyme, the SGLT2, in terms of its function. And we can see that the SGLT2 transporter is inhibited at very, very low concentrations, where SGLT1, you require a massively increased concentration of the drug to get the same level of inhibition. So that means we can give lower doses, and we're really going to be very, very specific for SGLT2 rather than SGLT1. So they are quite specific drugs. This figure 2, it was interesting, but basically showed they came up with a marker of where we can find SGLT2, and this was in a normal person, so it's mostly in the kidneys, a little bit in skeletal muscles, a little bit in the liver, and this is in a person who has a familial renal glucosuria that it was really just in their kidneys, and it was excreted into the urine as well too. Okay,
So,
sounds
Judy,
interesting. Yeah,
I don't look at PET scans, but
really.
to me, no, I don't. We're thinking of getting one for some reason, but um, the yellow in A, that's the liver, because
Yes. So
to
kidney
me
one,
that looks like
kidney
it's in the
two,
chest.
liver. Yeah, I think it might be related to the um, just resolution of it as well, because they do actually, I think, mention in the text of it that there was, uh, yeah, in the control subject accumulation was in the renal cortex and regions of the liver. So that is the liver, even though it looks like the caudal lung lobe that's there.
Okay,
But yeah,
yeah,
that is liver,
okay,
which they don't other than showing you on the PET scan that hey that this transporter is there, they don't really talk about it too much. Remember when we talk about how insulin affects the movement of glucose, insulin is binding to the transporter on the basolateral side, your GLUT2, your GLUT4 transporters, that is what insulin is going to trigger. These SGLT uh, transporters are not affected by your insulin concentrations. These are affected by your sodium gradients, and that's what's effective in transporting glucose. There are no SGLTs in the blood-brain barrier, so this does not affect your delivery of glucose to the brain, which is a pretty good idea, knowing that the brain derives all of its energy from glucose rather than being able to perform gluconeogenesis to any considerable rate and using fats and amino acids as energy, which is obvious. Our hypoglycemic patients come in, they're comatose. We give them a bolus of dextrose, they wake up, they feel normal, and that's because their brain cannot generate that energy. If there were SGLTs in the blood-brain barrier and we inhibited that, then we'd be making our patients comatose, which would prevent this drug from being effective. So that's good to know. Okay, and then let's go on a little bit more now. So now we're actually getting into the physiology that's there. So I always think this is a concept when I talk to the interns that I work with, they often don't completely understand what happens to glucose in the nephron. And we talk about this renal glucose threshold for glucosuria. And in man, it's usually about 180 or so, which is about the same in dogs. Cats, probably a little bit better, maybe 280. And above that serum concentration of those limits, that's where we expect to see spillover in glucosuria. And I think that word spillover is really confusing to students and people that are earlier in their career because they'll often misinterpret that and think at that concentration, you will then have glucose that enters the tubular filtrate when it wasn't before. And clearly that is very wrong. Glucose is a small molecule. It easily crosses the glomerular basement membrane. It is always there in the tubular filtrate. And it's up to these SGLTs in the proximal tubule to pull it all back. And if you think about it evolutionarily, our kidneys have evolved to save all of this glucose. Glucose we have hunted, we have gathered to get each and every one of our meals. We do not want to lose that energy in our urine. So we have very effective ways to do that. SGLT2, remember one glucose, one sodium molecule in the early part of the proximal tubule, followed by SGLT1, one molecule of glucose, two molecules of sodium in the later portion, but we're still talking about the proximal tubule. So our SGLT inhibitors are small molecules that are also freely filtered. So they're going to cross the glomerular basement membrane just like glucose is. So they are going to be present and they're competing for binding to those transporters. And when they bind to the transporters, we are unable to then bind and reabsorb that glucose. Once a glucose molecule makes it past the proximal tubule, there is no further ability for the kidney to reabsorb glucose. So if you make it through the proximal tubule, you are heading to the litter box, you are heading to the backyard. This is the only area that it can be done. So because we are only inhibiting SGLT2 with these drugs, we still have the function of SGLT1. And SGLT2 will only inhibit glucose reabsorption by about 40 to 50%. And that's because we still have SGLT1 that's there to make up for it. So as I mentioned before, the glucose uptake is driven by sodium. So this is not insulin dependent. It's driven by the sodium concentration gradient across that membrane. And I think, yes, so I'm going to skip ahead just so we can show this picture here. So here's our luminal concentration. These SGLTs, remember they're on the luminal side. Proximal tubule has all these villi present to increase their surface area. And glucose is going to move with sodium. And sodium is the driver. So the intracellular sodium concentration is very low. It's around 3 to 5 millimoles per liter. It's tiny. So we have this sodium concentration in the filtrate, which is going to be equivalent to your plasma sodium concentration. So 145, 150 millimoles of sodium are going to be present in the luminal space. You have this electrochemical gradient that's driving it to be reabsorbed into that proximal tubular cell. These SGLT2 transporters grab that one molecule of glucose and they will grab that molecule of sodium using the sodium gradient to shuttle both in. That sodium gets reabsorbed through our sodium potassium ATPase. That's on the basolateral side of the membrane. That's what's keeping your intracellular sodium concentration low and your intracellular potassium concentration high, and that allows for reabsorption of that sodium molecule. Remember from our earlier sessions that we've had on renal tubular sodium handling, about 2/3 of all of the filtered sodium is reabsorbed here. So there is a very high affinity, high capacity for tubular reabsorption through these mechanisms. Once the glucose enters the cell, the GLUT2 transporter is going to send it from the intracellular space into those vasorectal capillaries for reabsorption. And that's how we do not lose that precious glucose that we have fought so hard to be able to ingest. So our SGLT2 inhibitors are going to block this. So we are going to lose glucose. Glucose will go further down the nephron and be able to be in part recaptured in the later portion of the proximal tubule by SGLT1, as well as the sodium molecules that are being lost. But we will have glucose that's lost in the urine, and we will have sodium that's lost in the urine. And that is essential to how these drugs might work. Okay, let's go back here. Okay, I think we're okay to keep moving on. Here is just immunohistochemistry staining for the SGLT2 molecules. And we can see that they're all up here in the renal cortex. And when we look closer, we can see that they are in tubular segments that are all periglomerular, and that usually means it's going to be the proximal tubule because that's leaving the glomerulus. Now remember, the distal tubule does come back around and does sit close to the glomerulus as well too, but some pretty sophisticated studies have been done to show that these SGLT transporters are really just present in that proximal tubule. And that is it. Okay, let me just pause there, see if we have any questions, any comments, everyone all understanding where we're at so far?
I have a question.
Yeah.
That all makes sense in the paper. What I was curious about, and I'm probably just missing something, but the use of these drugs in type 2 diabetes just seems a little counterintuitive to me, and how increasing like glucose in the urine is going to improve insulin resistance, and whether or not the clinical signs of diabetes, like the PUPD, is going to be exacerbated by these drugs.
Yeah, so that's a really good question. And I haven't come across in people the effect, and I'm sure it's there, I just haven't seen those manuscripts that report what happens to urine output, what happens to their water intake. We do have some studies in animals, and so there are several studies looking at some of these drugs. And so in people, these are all referred to as Flozins, even though the original drug is Flozins. The class is referred to as Flozins, even though they are all essentially gluflozins. Apparently the glu is too hard to say, so we just call them Flozins. So a number of studies have been done using dogs as models for preclinical trials in people. And we also have a couple studies, and I didn't include the one that was most recently studied, which I think is the bexagliflozin, which is probably the one that's coming to market for feline diabetes. But it did show that there was, in this second study, that urine output did increase 60% and water intake increased 36%. So it did seem like these healthy cats who were given this Flozin did have increased urine output and did have increased thirst. And to me, I think that could be a very limiting factor for its use. Because we're going to talk about how these drugs have been shown to be beneficial in humans with kidney disease and heart disease. But if we cause this glucosuria and a osmotic diuresis to follow it, are we potentially taking these CKD cats that are kind of running around like raisins some days, and they're probably not running around, but they might have this chronic low-grade dehydration or sometimes overt dehydration. Are we potentially making that worse? And could we run into the scenario that these drugs could cause abnormal volume regulation in our patients that we struggle to keep them well hydrated with in states where there have no evidence of glucosuria? And I think that is a very tough scenario to think about. I don't know that any of the studies that have been done in cats for the product that's going to come to the market, I don't think they included any cats with CKD to see what those effects might be. But you're absolutely right. We're going to see PUPD associated with this drug, certainly it's been shown in cats. And I would presume that that's going to happen in people too. You're going to have increased urine output. I wonder if the diabetic people are not going to have much change if they are poorly controlled diabetics. So they're having glucoseuria anyways, and now we just cause glucoseuria but prevent its reabsorption, so their blood glucose might improve, but you might end up with the same magnitude of glucoseuria, maybe a little bit more. Maybe in people, they might not observe it. But I think that certainly has to be out there in terms of data. I just don't know that off the top of my head. But for sure, I think glucoseuria, polyuria, polydipsia that we would see with it could be a limiting factor in this class of drugs' utility in veterinary medicine. I think we'll have to see.
And do you know how the drugs actually improve insulin resistance?
So I think there's some data that hyperglycemia in its own right can perpetuate insulin resistance, partially due to altered gene expression of the GLUT2 and GLUT4 GLUT2 and GLUT4 transporters. So I know there are some theories about the situation that essentially hyperglycemia begets hyperglycemia, that you can have some resistance from a chronically hyperglycemic state. So it's possible that it could improve insulin sensitivity, but I don't know if anyone has specifically shown that. I think the labeling for the drug that's coming out to treat diabetes in cats is specifically going to be labeled for cats who have diabetes mellitus who have not received insulin. So I don't know if the company is proposing it as a superior therapy to insulin, but might be the niche of a therapy for cat owners who are unable to medicate their cats with insulin. Similar to how glipizide was used in the probably 90s, which was pretty ineffective. But I don't know if anyone's shown that it changes their responsiveness to insulin. The net effect would be, okay, you still might have insulin resistance, but you are going to have less hyperglycemia, so less of the consequences. You still might have intracellular starvation if your cells are not getting enough glucose transported to the inside of it. So I don't know enough about the endocrine effects of it, but those are all really good questions.
Thank you.
Yeah, of course. It goes into a little bit about how those drugs bind and how they inhibit the molecule. So this is your SGLT2 model. You have these two gates, an outer gate, an inner gate, and we have a molecule of of sodium, which enters first. That binds, opens this outer gate, and then the glucose molecule enters, and then they are passed inside the cell. So we'll have movement, and then they reset themselves. And the sugar moiety of these Flozin molecules will be thought to be a glucose molecule and have affinity for this transporter. So sodium comes in first, opens that outer portion. The Flozin comes in and binds, but because it's associated with this longer chain, we are unable to have closure of the outer portion of that transporter, which prevents opening of the inner portion. So this basically gets stuck. And in its stuck state, what needs to happen is that this transporter needs to be recycled. So it will get pulled into the intracellular space, it will be degraded, another receptor will be built, and a new one will be sent to the apical membrane. So they show this in a number of different ways, depending upon which model of biochemistry you like to look at. I like the simple pixel art, essentially, but that's how the drugs are working, and that's how they're inhibiting that molecule. Okay, let's go back a little bit. See if we're missing anything. We just talked about that. Okay, and then in the very end, it gets to really kind of what we want to know, or what are the effects of these drugs in our patients. So the initial study that was done that we're looking at using this drug in diabetic patients, that the FDA requires evaluation of drugs in patients with multiple diseases to make sure there's no contraindications. So a drug gets approved, but you will likely have to have a cohort of elderly people, or like a drug for diabetes, where most humans with diabetes die either of end-stage kidney failure or cardiovascular complications. Obviously, the FDA is going to require this drug, which is targeted at managing type 2 diabetes in people. Is it safe to use in people who have established kidney and cardiovascular complications of their diabetes? And surprisingly, what was shown is that there were benefits, that patients had improvement in their kidney function. Let me rephrase it. They had a preserved kidney function. They had less progressive kidney disease, and they had less frequent cardiovascular events, less heart failure, less progression to have hypertension and other consequences of it. And they are approved. So these drugs are approved for the treatment of heart failure. They are now part of the core drug cocktail that's used to treat humans with heart failure. And they are really become an integral part of the management of diabetic kidney disease and non-diabetic kidney disease as well too. So I think that's about the end. So any questions, comments, any sticky parts anybody have about this before we start to go into the actual benefits that we might see in patients with kidney disease, with heart disease? Everybody's pretty good here. Okay. So let's think about what's going to happen. You have inhibited your SGLT2. You have glucosuria, and that sodium is going to come with it. So you're going to have your osmotic diuresis from the glucosuria. You're going to have a natriuresis as well too, and that natriuresis is going to pull water with it. So that's going to increase your polyuria as well too. But you will have now an increased delivery of sodium to the later portions of the nephron. Remember that when we talk about sodium reabsorption, we are actually talking about sodium chloride reabsorption. Chloride is often reabsorbed passively through paracellular routes. So where we have sodium being absorbed through this transporter, according to the concentration gradient, chloride tends to zip right in between. So it will end up being electroneutral, and chloride is reabsorbed with it too. So when we inhibit this, we have increased sodium delivery to the distal nephron, we have increased chloride delivery to the distal nephron. So what is going to happen? This is going to trigger tubuloglomerular feedback, TG feedback, and we talked about this with the salt handling. This is a figure of essentially just that, TG feedback. So here's our lumen. Here's the apical surface of the distal nephron. So now we're talking about the distal tubule. These are your juxtaglomerular cells that make up the macula densa. We're going to have an increase in the amount of sodium and chloride that is present. That's going to result in an increased activity of the sodium potassium to chloride co-transporter. Remember, that is our target of furosemide. And that will stimulate the production of adenosine. And locally, you're going to have adenosine that will be released, and it's going to cause vasoconstriction of that afferent arteriole. So the way that I remember this is giving the kidney personality and giving it its ability to understand and be all-knowing, which of course it is. From an evolutionary standpoint, the kidney here in the macula densa, if it sees too much chloride coming down, it means that the proximal tubule has failed. It has not reabsorbed the sodium and therefore is not reabsorbing the water. And if we have a failure of that proximal tubule that normally reabsorbs 2/3 of all the sodium and chloride, we're going to have potentially massive natriuresis, which would cause diuresis. So the consequence would be increased urine output and risk of dehydration, hypovolemia, and death. So what's the response? If the upstream portion of that nephron is broken, the macula densa sees the excessive amount of chloride and it's going to try to shut itself off. So through this mechanism, it will have local release of Ang2, it will have local release of adenosine, and we have vasoconstriction of that afferent arteriole. So now we're going to have lower GFR of that nephron, and so we now become azotemic, but we're going to have less filtration, less sodium that can be lost. It's going to limit the volume deficit that would occur. So from an evolutionary standpoint, this TG feedback will trade uremia. I'll accept that so that I'm not hypovolemic and die. I can live longer being uremic than I can being hypovolemic. So it chooses the slower death, it maintains the host longer than if we would have that massive loss. So when we cause that afferent vasoconstriction, we should see that GFR would go down. And if we think about the other drugs that we use to treat kidney disease, like our ACE inhibitors also reduce GFR, but they do that by causing efferent vasodilation. So both would reduce the glomerular capillary pressure, and both would reduce GFR. One does it through afferent vasoconstriction, that's your SGLT2s. Your ACE inhibitors are doing it through efferent vasodilation. But both would be expected to cause a bump in the patient's serum creatinine to show, yes, these drugs are doing something. And when we talked about hyperfiltration and the maladaptive response to nephron loss, we know that those mechanisms, when we have kidney disease, the surviving nephrons have glomerular hypertension. They have a higher single nephron GFR to diminish they increase the workload of every surviving nephron so that you can have excretion of your daily solute load. And that glomerular hypertension, that glomerular hyperfiltration leads to glomerulosclerosis. It leads to proteinuria. It leads to subsequent changes that cause that nephron to now die. And that's the progressive nature of kidney disease. So by reducing GFR, by reducing that capillary hydrostatic pressure, yes, we would see a bump in creatinine, but the nephron does less work. There's less energy requirements of that nephron. There is less hydrostatic pressure. There's less opportunities for glomerulosclerosis. So our intervention would be thought to reduce GFR, but preserve it in the long term. And that's what these drugs, just like ACE inhibitors, are thought to do. And when we look at various tables that have come out in other papers, and I'll throw these other reviews in the Google Drive folder as well too, but this is exactly what I just went through. So the SGLT2 inhibitors decrease reabsorption of sodium and glucose. Increased sodium chloride delivered to the macula densa is going to cause afferent vasoconstriction, reduces that intraglomerular pressure. We have less GFR, but we have less proteinuria. We have long-term improvement in our kidney function. So we might expect to see something like this. So this is the change in GFR over time. And we have this initial reduction. And just like with our ACE inhibitors, we're going to see a bump in the patient's creatinine. We have some normalization, but the key is what we're seeing is this plateau, the stabilization, this diminished rate of progressive kidney disease. And so patients that would get a placebo would continue to decline. These patients who have this renal protective effect are going to have preservation of their kidney function over time. So we might expect our patients with CKD to have slower progression, longer survival, less complications associated with it, and remembering our model of heart failure. Heart failure does the same thing. Decreased renal perfusion is going to increase our RAS activation. We're going to have increase in our GFR as a result of it, increased volume expansion, inhibiting that volume expansion, which is maladaptive, could also have beneficial effects. And that has been shown in people. And when we look at these are the hazard ratios for the key outcomes, which is heart failure, death, kidney failure, progressive of kidney disease, or maybe some did doubling of creatinine. And this table is really nice because they break it down to those studies that had diabetic and non-diabetic patients, those that were just non-diabetic, and those that were. But you can see the hazard ratio. The hazard ratio is 1. There is no change in that risk of that outcome. And in all these studies, the Credence, the DAPA-CKD, the Emperor study, they all showed improvement in cardiovascular and renal outcomes. And this is actually one of the most substantial progress steps that has ever been seen in the management of chronic kidney disease in the last 15 years. There is no drug in the management of human kidney disease that has been shown to be more beneficial than the Flozins have in recent 10 years, 10, 15 years or so. This is similar to the role of ACE inhibitors and showing how ACE inhibitors were protective. These drugs can be used in people that are also receiving ACE inhibitors. They've been used in people with very low GFRs, and the outcomes are generally very, very favorable. I've yet to see a paper that showed that the drugs were associated with a worsened outcome in terms of kidney progression, cardiovascular outcomes, or survival. So let's pause there. We talked a lot about the drugs, their mechanisms, how they work. We talked quickly about TG feedback because we've talked about that before. Remember, TG feedback is one of the 3 main key renal physiologic properties. We have TG feedback, we have glomerular tubular balance, where essentially as glomerular filtration changes, you'll have a consistent proportion of function throughout the nephron. So if your GFR goes up, no matter what the GFR goes up to, the proximal tubule is still going to reabsorb 2/3 of the sodium, no matter what. So that's glomerular tubular balance. Then the third is renal autoregulation, where the afferent arteriole can dilate or constrict to maintain renal perfusion pressure, renal blood flow in a healthy kidney between a mean pressure of about 60 to 160. So those are your three: autoregulation, TG feedback, glomerular tubular balance, the three core intrinsic renal physiologic properties that are so important. So we've talked about that. That is review for all of us. We've heard about them, and this is where we're seeing them, those effects actually take place. So let's pause there before we kind of show, well, what do these drugs do in people, to make sure we're all on the same page. Questions, confusions, let's chat and see where people are at.
I do have one question. So,
Yeah.
when we talked about the mechanisms of decreasing the glomerular hypertension, we mentioned the potential for improving proteinuria, but in that one diamond study where they actually looked at that, they didn't see that. So I'm
Yeah.
just wondering how they, I guess, explain that in theory it should do that, but in reality we don't see that.
Yes. Excellent question. And we will, let me make sure there's nothing else before we'll jump into it. We'll talk about the diamond study first. Any other questions at this point? Because the diamond study was different than a lot of the other ones that were done. So this is diamond. So the diamond study sounds great. Non-diabetic patients with CKD, awesome. Randomized, double-blind crossover trial, great. But the duration of therapy, so was randomized crossover trial. So they got placebo for a certain time period, they got the Flozin for a certain time period, and it created this very, very busy figure here at figure 2, and it's looking at patients that were on the Flozin first, and then they were on placebo, or placebo first, then on the Flozin. And you can see that both the placebo and the Flozin were associated with a negative trend in proteinuria throughout the time. But one of the biggest differences with this study is it was a crossover study, meaning that the duration of therapy was actually quite short. So they only gave 6 weeks of the drug. So 6 weeks was not enough to see an effect. This is the big difference between the diamond study and the others. The others, the patients were randomized and they continued on placebo or the Flozin indefinitely, and it wasn't a crossover. So this is really our only short-term study, and it's likely that that 6-week duration was not sufficient enough to show a difference. And if you think about it, these patients already have CKD. They already have established glomerular hypertension, glomerular hyperfiltration, glomerulosclerosis. These Flozin drugs are really drugs that over the long term are going to decrease the rate of progression of kidney disease rather than cause an immediate change. So that's the big difference with Diamond. 6 weeks, short crossover trial. When we look at the other studies, they did show improvement, and it was mostly because of the different study design. They were placebo controlled and randomized, but there was no crossover. They continued to stay on it essentially until the patients died or the study reached its final endpoints. So if we look at, this is the DAPA-CKD study, this I think really shows the role of time. So if we're looking at, these are the various outcomes, renal specific outcomes, cardiovascular outcomes, the hazard risks for death. But if we look at the time frame, these patients need to be on it for really about 4 months before we start to see those curves start to change. Now the cardiovascular complications, those it's almost with like the first dose you're seeing improvement in the cardiovascular outcomes. But where those really start to split, we're talking about 8, 16, 20, 24 months, which I also worry might be a confounding factor or limiting factor in the use in our patients. If these drugs work well and the longer they're on it, the better the effect might be. Are we going to see an improvement if we are giving this to cats with stage 4 CKD, dogs with stage 4 CKD? Are they going to live long enough to have that effect? So when we think about that 6-week duration of Diamond, we are essentially right here. And so it really seems like these drugs need time to work before we start to see these improvements start to occur. So in DAPA-CKD, dapagliflozin was associated with reduction in all of the outcomes, death, cardiovascular outcomes, which was heart failure, and then progression of kidney disease. All of those were shown to be improved. When we look at this is Emperor, I believe. No, this is EMPA-CKD. This is the one that I think that just came out, that I sent everybody as a bonus. So again, looking at the time, this is years to follow up. And so this is about a year do we see this really start to split and we start to see the placebo work differently. We don't have a lot of data in terms of survival of chronic kidney disease in our patients. We have a couple studies. I don't agree that the published survival rates are what I see clinically. I think the median survival for a stage 4 cat with CKD is somewhere along the lines of like 1 month or 3 months or something like that, which stage 4 is so big, you can have a CRAD at 10, that cat's not going to do very well, but you can also have a CRAD of 5.5, and that cat probably going to hold on for a little bit longer. I do worry that the time it takes for these drugs to maybe show their effect, we might not see that if we're starting later on. So this might be a drug that we want to start in earlier stages of kidney disease, or at least design the study where we're really starting in stage 1, stage 2, maybe stage 3, maybe excluding stage 4, and seeing. And if you think about it, your stage 4 patients are probably the ones that are going to have a challenge with their hydration more so than the earlier stages. And the last figure I wanted to show is that this is, which one is this? This is Emperor. This is empagliflozin. And if we look at that theoretical reduction in GFR, so this is the change in their GFR from baseline. If we look at, sorry, I'm bouncing around. If we look at this figure, what we expect to see, this initial reduction in GFR, and then stabilization, plateauing, and a diminished rate of CKD progression, that is exactly what was shown here. So we see that the Flozin reduces GFR, and that's because you have that afferent vasoconstriction. But over the long term, we have sustained GFR. We have the kidney function be preserved, where the placebo patients continued to have a decline in their disease. And again, look at the timeline. We're a year at this point. We're 2 years at this point. Now, people live a lot longer with kidney disease than our patients do. It has been hypothesized that if you have shorter disease, you might have shorter effects as well too. So disease that progresses faster, we might have more of these effects, but the answer is we just don't know. I'm not aware of any study that's been done in dogs, even with experimentally induced kidney disease, as a model for people with kidney disease. I'm not saying it's not out there, I just haven't been able to find it. So we don't know the effects. But I think it's a drug class that has potentially a lot of benefits. It potentially could make PUPD worse, and we might have negative effects that maybe the owners are not going to be happy that their dog or cat is more PUPD, and maybe it's going to affect their quality of life. But these are all questions that we still need to answer, that we just don't have a great understanding of yet. So we're almost at the end of the hour. I want to stop there and just really open it up for questions, thoughts, comments on the potential role that this drug class could have in our patients. People have concerns, people have questions. Let's open it up and see what everybody's thinking at the
Well, I'm thinking about fluid balance. I'm not sure if we have data of these glyphosins and the trials in people according to their capability to produce urine or not in CKD patients. Because now, in fact, we know that even in heart failure, the main concern is congestion even more than hypoperfusion. So in our population, we don't tend to see that much congestive states in CKDs. Yes, of course, in heart disease, but not that much in CKD patients. I'm not sure if, I mean, these DFRs tested correlate with urine output as well. I assume yes, and I assume that I just assuming I have to check that with the classification in humans, that the lower their GFRs, also they are more uh, retaining more fluids. So these glyphosins make a lot of sense for other mechanisms, of course, different than the proposed here. So I'm not sure if we have data where we can know how much congestion these people have.
Yeah, it's an interesting thought, and I think that because it's approved for the use of congestive heart failure, by essentially causing the osmotic diuresis, you can get some volume off of these patients by starting a Flozin. So I think these drugs are used fairly early on in congestive heart failure to help with the diuresis to decongest the patient. Obviously, they're using other therapies as well too, but this is something that these patients are probably getting started on in the hospital. And I do think the idea of volume control and maintaining hydration is a huge unknown in our patients. Our people can be a bit better in terms of just drinking more. Most people, as you kind of insinuated too, that when they have reduction in GFR, most people who are on chronic dialysis are anuric. So urine output tends to go down. They don't have nearly the magnitude of polyuria that we see in our dogs and cats with CKD. So I do think that's absolutely a factor that is unknown and could be prohibitive for using this drug in many patients. So I think I think this class is really in need of study of our patients, but it could be a study that shows, yeah, great, it does it, but the side effects or the quality of life is terrible, and it's not a class that's associated with improving the quality of life of our patients. Um, but I think it's worth investigating because, man, if we could preserve kidney function, it's diets have
Yeah.
really been the only thing that have been shown to do that. We don't have data showing that ACE inhibitors do that in our patients like they've been shown in people. And that's probably because the studies are underpowered. The doses have been quite low, like a quarter mg per kg once or twice a day of an ACE inhibitor is, I consider, homeopathic. So we don't have that data. So the only evidence we have in the slowing the progression of CKD is diet. Even when we talk about controlling blood pressure, controlling proteinuria, we don't have a single study that's been performed showing if you do that, if you control blood pressure, if you control proteinuria, their outcome is better that I'm aware of. And someone can prove me wrong or let me know if I'm missing a study. But we know that those are risk factors associated with a worse prognosis, a faster progression. But I don't think we have any evidence to show that therapeutic intervention and correcting it actually improves outcome. We think that it does, but I don't think we have data.
Yeah, I agree with you, JG, and I think that when I was reading the papers, I think if we're gonna like draw like a big study, I think the most limiting thing for us as veterinarians is defining the individual EGFR, right? All of their studies, they do have that urinary glomerular filtration rate from all their patients, and we'll still like are behind with serum creatinine, which we're gonna expect like a increase of serum creatinine, and then we get into that point of like the AKI standards of like KDIGO says that the increasement of the zero point 0.3 48 hours, so that's being induced by the drug. Um, that kind of like, are we are we are we decreasing? Is that like beneficial for them, or how will they tolerate? What's going to be the perfect like dosing target if we don't have the EGFR of them?
Right.
Because we have like we are lacking of that individual. I don't know. Maybe I am outdated though, but I think a great start is when we could find like a mathematical, or I don't know, about another calculus that could provide us such information to have their individuals EGFRs. And then it's interesting that the last study that you shared, it was kind of like, so the criteria was the patient should be like undergoing a RAS blockade associated with a SGLT2 inhibitor plus a non-steroidal mineralocorticoid receptor agonist. So there's like a lot of like blockades along the tubular, right? So we don't even know how the inhibitors behave, and we don't have the cutoffs. I mean, I think that if we could decipher their animals EGFR, would be way beneficial for us to see what are the targets and what are the limitations of using these drugs, like at early stages or mid stages or at advanced stages. But yeah, it's someone has to start it, right?
Yeah. And I think EGFRs are going to be so hard because in dogs, they're so different. And
Hmm.
remember, there are essentially different reference ranges for GFR in dogs depending on how big you are. That smaller dogs have
Yeah.
higher GFRs than larger dogs, except for the giant breed dogs that all of a sudden their GFRs went up again. Some of that is going to be related to muscle mass, renal perfusion. Cats are probably a bit easier. They're about the same metabolic size, even if we have some fat cats and some skinny cats. But remember, we can always just measure GFR, and we could do iohexol clearances. We could do endogenous creatinine clearances. We could do exogenous creatinine clearances. So there's a number of things that could be done so that we can actually quantify GFR. Short of that, we can look at SDMA, we can look at creatinine, we can look at cystatin to have be markers, but we know that there are limitations to all of those. So I think it would be a really interesting concept to be able to get a group together and develop a multi-center study. We obviously need the drug. So it would be great if a drug company would be interested in extending their use of this drug that will be labeled for treating diabetes in cats for other things. I'm just excited that we have a Flozin that is shown to be tolerated. We have a therapeutic dose that does it. We don't have to be taking Farxiga and breaking it up into 8 tablets or something like that. So it's exciting that we're going to have something available. I think we just need to come up with a study and ideally see if we could have funding so that it could be placebo-controlled, blinded, multi-center prospective evaluation of these drugs to see, does it do anything? Do they make it worse? Do they make it better? We just don't know. But it's become such a mainstay of managing CKD in people that I hate to be missing out on something that our patients could benefit from. Obviously, I don't want to give it to them if they all dry out and they become dehydrated. We're doing more harm than good, but I don't think we know that information at this point. All right. Any other thoughts, comments, questions on the Flozins? My parting comment will be a complication that you can see of a Flozin in a patient, and this is obviously true in people, but we need to be thinking about this in cats, being the smartest people when it comes to electrolytes and acid-base balance. That is all of us. One of the coolest adverse effects you can see with this is a euglycemic diabetic ketoacidosis. So they come in DKA, but their glucose is still 150. That sounds awesome, and I'm excited to see it and to manage that. Well, the electrolyte part, the insulin and whatnot, like someone else can deal with that. But that's something that's not going to be on people's radar unless they're really familiar with the drug and they've seen it. And I think especially a lot of our ER doctors that are really good, if it doesn't trickle down to them, they might get a blood gas on a patient. They see they have this gap metabolic acidosis, but the glucose is normal or minimally increased, and they might not be grabbing a ketone meter to check, but you could, and you're going to see that, yes, they have ketoacids. That's the cause of your increased gap metabolic acidosis. So it's a euglycemic DKA. Awesome. I'm excited. Okay, with that, let's close this session. Thanks, everybody, for joining. I will send the recording out. We'll post it up. Well, I'll post it on the website, and I'll come up with the articles for next month. I think we'll still be good for next month because it should be early December, so hopefully away from enough from the holidays that most people will be available. But that'll be our last session of the year, and then we'll keep rolling throughout 2023 as long as people find it interesting and helpful. We'll keep going. So thanks everybody for coming. Hope you have a great day, and I look forward to talking to you all soon.
Thank you,
Thank you so
Gigi.
much.
Thank you, everyone.
Great.